Good morning. My name is Schmeltz. I'm in private practice in suburban Detroit, associate professor at Oakland University, William Beaumont School of Medicine. Like Sean, I also started RFA in 2021, so 3.5 years. And like Sean, as a pioneer, obviously in my practice of 10 practitioners, and none of them sort of knew anything about it. And so to get over the hump of creating and building an RFA program in the private practice world, I'm happy to share the experience. So outside of the program, the rest of the day, if you guys in private practice have questions, happy to chat a little bit longer. And Sean did cover a lot of good bullet points, and so I'll try and skip over the redundant stuff to get us back on time for Brian's sake. So of course, you know, thyroid ablation really came out of the patient desire. My first patient who wanted RFA had these very large compressive nodules, and he said, "Doc, I'm not having surgery no matter what you say, find something else." And that's what led me as a practitioner to investigate, is there something else? And that's how I went and got trained and started doing RFA. And of course, he's the one patient who hasn't had the procedure yet. So the goal is to preserve thyroid function. Remember, you're ablating nodules, not normal tissue, which is why the risk of hypothyroidism is so low. Most of the patients truly say, I do not want to have surgery, either whether they're scared of anesthesia, scared of the potential surgical complications. And again, the technique and the equipment just keeps advancing. And again, I expect over time our clinical efficacy and safety is going to continue to improve. So why is this, in my mind, one of the ideal treatment options? It resolves the compression symptoms almost by, I do a 6-week follow-up for my first check. My symptom scores, which I'll show you in a few minutes, drop tremendously. And when I ask every patient at that first 6-week visit, knowing everything you knew about the procedure before, having gone through it, and now here at our 6-week visit, would you choose the same thing again? And almost every single person has said yes. The only one who said no did it for cosmetic reasons against my knowledge. And so again, it's hard to promise cosmetic results. And so I'd encourage you to stick to patients with compression or autonomously functioning nodules. Again, the fact that it's outpatient has pretty much no scarring. It's an 18-gauge insertion with the antenna, and low risk of complications, again, when done in a qualified program and with a good experienced person doing it. So benefits of adding RFA to a private clinic. In a private clinic, again, I'm the boss. I'm the one making all the decisions, and I'm the one who can sign the contracts with the companies and make things happen relatively fast. So in a private practice compared to an academic center, which can take 6 months or a year to get the program off the ground, I was able to get this up and running in about 2 to 3 months. Again, StarMed did amazing support, not only for the first cases, but even moving forward with marketing and other things that I'll highlight. In a private practice, again, streamlined processes, generally lower costs, and flexible scheduling. Pretty much if I see a patient on a Monday and they're really dire, they want to do it, but if I have time on a Thursday or Friday, boom, we're already scheduled. So again, I've developed a referral network in my community for the minimally invasive option. Originally, the endocrine surgeons a few years ago, a little hesitant locally, but now they're one of my big referral sources. Practice revenue obviously goes up. In endocrinology, we don't have many high revenue generating procedures. There's only so much continuous blood sugar monitoring you can charge for it. And so besides ultrasound and biopsy, definitely improve the revenue in our practice. Our practice happened to be a thyroid referral center for 75, 80 years, has been known as a thyroid referral center, so we already had good marketing from that standpoint, but you can really establish yourself as being a thyroid center of excellence doing these advanced treatments. And again, in private practice, what I focus on is being efficient. We don't want to take up too much staff time. We don't want to, we're watching our equipment costs and everything else. And so it can be done in a private practice quite efficiently. The other thing from a patient experience is, in my practice, I call it the red carpet treatment. So we treat all patients well and nice, but for our RFA patients, they get about an hour and a half blocked out from they get in and change. They get these ice packs, they get the extra bottles of water, they get pretty much the red carpet treatment amongst my staff. It takes 2 employees who assist me with the RFAs, so it doesn't take up a tremendous amount of staff resource as well. The positive patient experience is what drives the growth. The more patient positive experience you have, or positive patient experiences you have, the word of mouth referrals really go up. Patient retention, a lot of the patients referred from outside clinics, even though that's not my intention, choose to stay with me. And trust me, I'm busy enough, but it's still nice to have some loyalty amongst patients. And then the online reviews definitely, again, boost private practice across the board. For those who are not familiar, there is a Facebook group called Save the Thyroid. I know it's Save Your Thyroid. I know it's kind of funny. I tried to join it as a practitioner, and they kicked me out after a few days once they realized I was a practitioner. They don't want us marketing to patients in there. But this is a moderated group that go over patients interested in non-surgical options for their thyroid. And so I refer patients to this group constantly, so that way they can get their fears alleviated that RFA might be appropriate for them. There are patients in there who post their experience across the country, across the world with their RFA, and takes the anxiety off patients. If you do a good job, your patient might post in here, and therefore it is wonderful marketing to help build your practice when patients start coming from out of state or wherever you are, because you had positive reviews online. So what does it look like? What are the financial considerations in your practice? There is an initial investment in both equipment and training. You guys saw the equipment upstairs with the generator, the water pump, and then you have to purchase the probes, which are one-time use. Again, high return on investment once you get going. I estimated, based on my costs, it was about 90 cases to break even with the investment. And again, your financial model might change based on your practice. Insurance and billing, I've been quite successful with insurances, even though the local insurances in Michigan are not very good with coverage for RFA. About a third of my patients, I do get coverage. It does take a prior auth process. It does take phone calls for peer reviews. If I get a surgeon on the phone for the peer review from the insurance, my odds are very low. If I get a family practice or internal medicine doc on the other end of the line who understands lifelong thyroid replacement therapy, then they're like, wow, that sounds like a great alternative. So now if they schedule me to talk for a peer review with the surgeon, I say I'm not available and I try and get a different doctor. But there is obviously cash pay out there, and a lot of patients who insurances are not willing to cover are very, over time often, willing to accept the cash pay option. And whether there's care credit, just like surgeons often use to get patients assist with surgeries, care credit has been very helpful in my practice to get those patients who are nervous about the cost and helps them out over a year. The big highlights is Aetna and Cigna nationally have started covering as of December 2023. Both do require a pre-authorization and do require an indication for high risk for surgery. Now that's a very vague term, and I've had some very loose reasons why I've put in my letters, but so far all have been approved. I know there are some Blue Cross, Texas, Illinois, Arkansas that are covering it, and my hope is that more and more will cover it over time. But cash pay is still the most profitable, so if insurance does pay, it often is less than what we charge cash pay, and again, that care credit has been able to help patients significantly. When you do get up and going, again, what I did was I sent a letter to all types of referring physicians, all the endocrinologists around, endocrine surgeons, ENTs, generally my referral source for thyroid nodules. StarMed was gracious enough to help me with patient brochures that had my face and name and stuff on the back of it. I advocated to present grand rounds. I probably did 8 to 10 grand rounds at hospital systems around me, internal medicine, surgery, etc. I have, like many, built a website that answers frequently asked questions, utilize social media a little bit, and patient testimonials also go a really long way. I will say that Facebook Save Your Thyroid group has probably been my #1, both for my own patients, posting nicely in there. It has been a great referral source for me. And you can host informational seminars and webinars if you want to continue to educate both the community or other practitioners in your area. Again, it's all a matter of marketing, promotion, cost, depending on how much you want to invest in it. So implementing RFA in a private clinic, what I found the most helpful is I identified sort of a manager in my practice. It doesn't have to be your office manager, but one person who's going to understand the process, understand the business side, understand the proper indications, and can gather all the reports so that before a patient is even scheduled for an RFA consult, I know that we have everything that we need to move forward, and they might have already had the discussion, well, we know your insurance will not cover this, and so you would have to be a cash pay, and therefore it saves the inappropriate consult for a patient I have no chance of actually successfully doing an RFA. We developed a good pre-authorization workflow. We have a standard appeal letter that goes to the insurance companies that some insurances triggers the peer-to-peers. We know exactly which notes and reports. Brian, I believe there still is a third party working with StarMed to help you with prior authorization process, to learn that process. to assist you in the prior authorizations. But before you do your first case, doing a hands-on walkthrough like you did today is very important. But it's kind of like dancing with your staff. You really need to do a walkthrough with the staff, with a phantom on the table, on things you might need, things you might, try and predict for them what they're going to need to be doing during the entire procedure. And then finally, get practice. The phantoms that we used upstairs, again, some were good, some phantoms were not as good, but there are recipes out there to make phantoms. Practice, practice, practice. And again, the more biopsies you've done and are comfortable with that longitudinal transithic approach, the more successful I think you're going to be doing your first RFAs. So for example, a phantom you can see here, someone ablated small little areas. Plenty of viable tissue still left. Over time, when you practice, you can see a much more thorough ablation. Again, you don't need to get 100% of the viable tissue to get a successful ablation. What I've learned over time is if you get a good 60 to 70%, you're generally going to get a good volume reduction. Obviously, the larger percent, the better. But as Sean mentioned, you want to stay away from your danger spots. You want to leave a little fluff of tissue near that danger triangle with recurrent laryngeal. And also, if you're concerned about the vagus and some of the lateral structures, it's okay to leave a little bit of tissue there as well. So you don't need to be a perfectionist in trying to get 100%. So in our office, our workflow, 1 week prior to the RFA, we collect any payment or copays, and we have changed our workflow on this because some patients didn't realize that, oh, insurance is covering it, great. But meanwhile, they had reset their deductible, and now they owed a few $1,000s on their deductible, and they weren't prepared for that. Pre-procedure labs that we do, thyroid function tests, I include thyroid antibodies, more so that if they develop hypothyroidism 10 years from now, they can't look back and say, oh, it was from the RFA. If they had positive thyroid antibodies, we knew there's a predictive risk of developing hypothyroidism. We do get a CBC and PT and INR, again, just due to the bleeding risks. And the anxiolytic type generally, and Valium, 5 or 10 milligrams for patients. Again, if you over-snow someone, then they'll start singing during it, little old ladies, as was mentioned. So yes, lower doses for those patients who are naive or you're concerned about too much. But I have used Ativan and Xanax, patient preference. Procedure day, things you don't think about, but you might want to for our patients. Remember, they can't have any metal on their body. So bras, you need to often have a sports bra, something with plastic clasps. They generally want to wear shorts so you can put the grounding pads, electrodes, something you might not have appreciated upstairs. Underneath the phantoms was a grounding pad, and those generally go on the thighs. So men do have to shave their hair off their thighs to make them stick. Getting the consent form signed before they're snowed, that was a great reminder, Sean. I like that. And then make sure the patient goes to the bathroom right before the procedure. If you're mid-procedure with the antenna in their neck, the last thing you want them to say is, I gotta pee, because that is not a good situation for everyone. In terms of not eating, I put a little table of what we do in our practice. Generally, they can have a general meal about 8 hours, but I don't want them having liquids 2 hours before. So again, depending if you're doing a morning or afternoon case, might change how you advise patients. So this is the setup in my office. We have a laptop ultrasound, and so I wall-mounted a larger TV. What that allows is for my staff to be able to sort of see quite well. They don't have to peek over my shoulder. And at this point, they generally know where I am in my ablation. They can predict when to turn the machine off, when to turn it on, and really know when we've mostly completed. I can predict my movements really before I do it. Make yourself comfortable. Again, many of you are surgeons or radiologists, maybe are used to an interventional room. For those of us endocrinologists, for a biopsy, we can be uncomfortable for a minute or 2 minutes and not worry about it. I'm right-handed. I do my left-sided biopsies from behind the patient's head, kind of where the gentleman's sitting here in this picture. But my right-sided biopsies, I raise this table up and move over to the right side to do transithic. And so when it comes to RFA, I've been mimicking that. But you got to make sure that you're comfortable. Because again, these procedures can last anywhere from 15 to 45 minutes, or if you have a very large nodule, even an hour. If you're not used to standing for a procedure, being a non-surgeon, it takes a little time to make yourself comfortable. Again, staffing, I generally have 2 people, one to work the machine, turning it on, turning it off, doing our timing. The StarMed logger is helpful in assisting with that data gathering. The second one to assist if we need 2x2s, if there's any oozing at the insertion site or anything else to make the patient comfortable. If you're in a hospital, you're more likely to use a sterile environment. Us in private practice generally use a clean environment for all our thyroid biopsies, and I still use a clean environment for my RFAs. I do use chlorhexidine on the skin more than just an alcohol wipe, which I use during biopsies. We do put sterile drapes just over them so I have a workspace, but everything else is done under a clean environment. Again, the large ultrasound monitor, if you have one on your machine, great. If not, that wall-mounted one really has made a difference. Turning the generator on and off, there are foot pedals available. I just have my staff turn it on and off, and that way it's very purposeful. As Sean mentioned, you don't want to be moving around with the probe outside the nodule with the probe that's accidentally on. And so again, that's my fear a little bit with the foot pedal. The generator makes a good sound to know when it's on and off, but something you should conscientiously think about. And again, that StarLogger app has been very good. And then music. Recently, I don't know if anyone read the journal article, there was a biopsy pain paper that showed if you play music, there's less pain during procedures the patients report. So as of last week, we were starting music during my RFAs. Why not follow the data? So what's the learning curve look like? Upstairs, we use the adjustable Viva 2 electrode. Picking which electrode to use, again, that's strategy that goes into your planning. Depending on the size of the nodule, you might choose a larger tip. Smaller nodule, you might choose a 5mm tip. With the adjustable, that's great. Again, you just can't make the probe needle tip smaller while it's inside the body. And so, again, 5, 10, 15. I believe it's 7.5 and 12.5 on that as well. So you have a lot of different options. 3 centimeters? Where to do the insertion? Again, on a demo that we did upstairs, not a big deal, but there are physics involved. The probes are so long, and depending on where the insertion is, you just need to fan up and down to make sure you don't run into the chin, and you don't run into clavicle, or in some females, large-chested females, you run into physics issues where you can't get the probe where you want to because there's a structure. So if you insert too high, insert too low, you might not be able to reach certain aspects of the nodule. So I purposely spend an extra minute or two with the patient on the table pre-procedure to figure out the optimal insertion location. Wattage variability, everyone you speak to has experience with RFA will tell you their approach to wattage. I'm sure Dr. Beck uses a much higher wattage than I do as an endocrinologist who is still obviously learning through the process of how aggressive to be. Near the danger areas, I purposely use a lower wattage, and as we get to the central area, crank it up and ablate. But every nodule is a little different with density, and so you'll learn over time what the optimal wattage is and your movement speed with your probe to make it work. Many of us have realized that most successful volume reductions come when you ablate the feeding vessel. Try and identify with Doppler ahead of time any of the larger arteries or intrathyroidal vessels that seem to be feeding the nodule. Getting the vascular ablation really does make a big difference. Some people do it early in the procedure, other people do it at the end. But before I finish my case and take the probe out, I always Doppler to make sure that there's no significant blood flow to the nodule. Again, there are thyroid vasculature procedures being done separately to see that same success. Water temperature, we had ice buckets upstairs. The water was really cold. Keeping that tip of the probe is essential for larger cases that take a long time. If you're using a bag of IV that's been frozen, then the temperature starts going above 15 degrees. You can run into issues with tissue sticking to the probe. And so I'd encourage you to always, someone in the room should keep an eye on the temperature, making sure that does not go up too much, as it'll affect the efficacy of the probe. And then finally, what to do when the ablation is not going smoothly. And this happens especially early on as we're learning anything. And so again, whether having support, whether having another colleague around, or just taking your time, pausing, making sure you know where the needle tip is. Are you in the solid tissue? Is this a fluid pocket? Or have you accidentally gone outside and are, if there was a little bleeding around the nodule, are you actually trying to ablate hematoma versus ablating the actual nodule? So these are just small things over time. You need to get in your head of, okay, what's not working here to finish the case. And then finally, you've got to ask, can I move around the room if needed? Sometimes you do need to stretch, move, etc. And if you have a ton of cords with a ton of equipment, sounds trivial, but once you're locked in a corner of a room and can't get out because of all the tubes and antenna and ice tubes that are leading to it. Just make sure you have a clear path and your staff has a clear path to move around the room. Post-procedure follow-up in our office is simply apply ice to the neck for 15 minutes, verify that there's homeostasis, no worsening of compression symptoms. That's where I do my quick voice assessment. I do not do laryngoscopy. I simply ask the patient to tell me their address throughout the procedure. And so that's generally with an ear can hear whether the vocal cords are intact. I do follow-up at 6 weeks and 6 months. That includes ultrasound and thyroid function tests. This includes my autonomously functioning nodules. Someone asked the question, how soon will you see improvement with an autonomously functioning nodule? By 6 weeks off anti-thyroid medication, I've seen the people who are going to resolve. And so if they're on methimazole or PTU at the time of procedure, I have to stop it that day. And then at 6 weeks, if their TSH has come up, I know it's going to be successful. And the data in the literature is about 80% of autonomously functioning nodules will normalize TSH. If not normalize, at least get significantly better. I do call the patient the day after RFA. I know it's sort of that red carpet treatment, but I want to make sure that from a pain standpoint, they're doing well. From a bleeding standpoint, there's no issues. The only patient I had that significant hematoma that went down to the chest wall is a guy who went and played golf the next morning, against my advice of taking it easy for the weekend. So I generally tell people to take it easy for 2 or 3 days after the procedure. But if I do procedures on Thursday, Fridays, almost everyone's back to work by Monday. Recovery time is generally 48 hours for most people. Very seldomly does it go beyond that. So my first 91 cases, that's where the data I've actually been able to compile so far. I've done more cases, but this is the data that I had. Our baseline symptom score of 5.8. At 6-week follow-up, it's down to 1.3. Symptom score is simply the question, on a scale of 1 to 10, 10 being a rip this out of me tomorrow, how much is this nodule bothering me? And so I asked the question at every visit, and cosmetic score is on a 1 to 4 basis. And so again, from cosmetic score 3.2 down to 1.0. So my average volume, 37.3 going down to 19.1, so a 54% reduction, 55% reduction by 6 weeks, and averaging about a 70% reduction by 6 months. And largest nodule dimension, this is again on average 4.9. Someone asked me earlier what's the largest. I've done a 12 centimeter, I'm sure other people have done bigger, with a volume of 212 is my largest. And again, even though it was 12 centimeters and it goes down to 7 or 8, the compression is dramatically better and their symptoms are often dramatically better and symptom score goes down. Tracheal deviation averages 1.1 centimeters down to 0.4 to 0.2 by 6 months. And again, my average wattage, this is where I'm the endocrinologist whip here. I average about a 41 watt ablation. I'm sure there's others in the room that would average 50 or 60 as they move on. And the average ablation time for this average 37 ml nodule is about 11 minutes, 44 seconds of actual machine-on ablation time. And again, you'll see that vary amongst different people doing the procedure. But so far, I've been lucky, knock on something, 0 complications from my procedures. Again, outpatient, I do not have a hospital, I do not have backup, I don't have a surgeon at my beck and call. It's a 25-minute drive to the hospital should someone need it. So yes, there are times when I say, you know what, I've done enough, I don't need to get overly aggressive, but it can be done safely and efficaciously in a private practice. So here's a patient who gave me her social media post that she posted on that Save the Thyroid group from before all the way to 6 weeks after. And in our office, I feel like we've been able to do this as a very streamlined process. Generally speaking, lower costs. I don't know what costs are in the hospital, but I feel like we've been able to keep our costs to a minimum and at the same time enhance the patient experience, give them that red carpet treatment, less stressful for them, not going to a hospital, flexible scheduling. And again, as a startup business person in a private endocrine practice, I can tell you this is very financially viable. I'm very curious to see what the new CPT code as of January will, and what that translates into reimbursements. I'll see if I say the same thing next year at a conference like this. But I will say being my own boss is priceless. So thank you guys. I know Brian's trying to keep us moving, so if there's any questions, we can take 1 or 2, and then otherwise I'll be around all day. I'm happy to answer.
To measure the tract elevation, how do you measure tract elevation?
How do I measure?
Tracheal deviation.
Tracheal deviation is simply me as a diagnostic, ultrasound person, how much it's varying. I line up their chin with their sternum, and I'm seeing how far it's going to a side. So it is my visual on ultrasound.